Hello guys. This is Dr. Rizwan Mirza. Welcome to my channel at Gerdologist.
Hello guys. Have you recently developed hematuria, which is blood in urine? Did you recently had febrile episode and infection, particularly respiratory infection or skin infection? Have you recently noticed rise in your blood pressures? Does your labs show raised creatinine? If yes, there is a possibility you have developed IgA nephropathy. Let's discuss it today. IgA nephropathy is also known as Buerger's disease. It is a kidney disorder characterized by the deposition of immunoglobulin A, IgA, antibodies in the glomeruli, which is the filtering part of kidney. This IgA deposition leads to inflammation, kidney damage, and impaired kidney function. IgA is an antibody that is part of the immune system's defense against infections. Main pathological problem in IgA nephropathy is an overproduction of IgA antibodies, with some of them being deposited in the glomeruli. This leads to inflammation and can damage the kidneys over time. The exact cause of IgA nephropathy is not well understood, but it is believed to involve a combination of genetic and environmental factors. So, primary IgA nephropathy is idiopathic and there is no specific cause leading to IgA nephropathy. Secondary IgA nephropathy can occur due to multiple reasons including different infections and diseases. Most common association leading to IgA nephropathy include chronic liver disease, usually alcoholic liver disease, and HIV infection. There is another type of IgA nephropathy which is familial, that includes certain gene mutations, leading to IgA nephropathy. Clinical features in IgA nephropathy include 1. Hematuria, which is blood in urine. It could be gross hematuria or microscopic hematuria. 2. Proteinuria, which is protein in urine. 3. Hypertension. 4. Edema. 5. Decreased urine output if nephropathy has caused acute kidney injury. Diagnosis typically involves a combination of clinical evaluation, urine tests, blood tests, and a kidney biopsy. A kidney biopsy is necessary to confirm the presence of IgA deposits in the glomeruli. Findings on kidney biopsy include the following. On light microscopy, we might observe 1. Mesangial hypercellularity, which is most commonly diffuse and global. But focal segmental hypercellularity can also be seen. 2. Crescentic change may be seen. 3. Mononuclear cell infiltration is associated with tubular atrophy and interstitial fibrosis, leading to widening of cortical interstitium. It indicates poor prognosis. On immunohistology, we will observe 1. IgA deposits in renal mesangium. In 15% cases only IgA deposits are seen. 2. In 50 to 70% cases IgG deposits might also be seen. 3. In 31 to 66% cases IgM deposits might also be seen. 4. Complement component C3 might also be present. On electron microscopy, we will observe 1. Mesangial and paramesangial electron-dense deposits corresponding to IgA immune complexes. 2. Glomerular capillary wall deposits may be seen in subepithelial or subendothelial spaces. It is associated with more severe disease. 3. Glomerular basement membrane abnormalities are seen in 15 to 40% cases, associated with heavy proteinuria and crescent formation. 4. Some patient might experience thinning of basement membrane, indistinguishable from thin basement membrane disease. Let's discuss Oxford classification of IgA nephropathy, which is based on histological findings, to make the score and assess the severity of nephropathy. It includes 1. Mesangial hypercellularity, 2. Endocapillary hypercellularity, 3. Segmental glomerulosclerosis, 4. Tubular atrophy, 5. Crescents. The prognosis for individuals with IgA nephropathy can vary. Some may experience a relatively mild course with minimal progression of kidney damage, while others may have more severe kidney impairment, potentially leading to chronic kidney disease or end-stage renal disease. Features that indicate good prognosis include recurrent gross hematuria. Features that indicate worst prognosis include increasing age, duration of preceding symptoms, severity of proteinuria, hypertension, reduced GFR, increased body mass index, and high serum uric acid levels. Treatment of IgA nephropathy depends on the symptoms and level of renal involvement. So for recurrent gross hematuria, no specific treatment is advised, but only supporting measures are taken. If patient has proteinuria but it is less than 0.5 grams in 24 hours with or without microscopic hematuria, no specific treatment is advised. There is no role of tonsillectomy. But if the proteinuria is more than 0.5 grams in 24 hours with or without microscopic hematuria, first maximal doses of ACE inhibitors or ARB is prescribed. But if proteinuria persists, and remains more than 0.5 grams in 24 hours, then immunosuppressant medications are prescribed for about 6 months. If the patient has developed acute kidney injury and he is diagnosed to have acute tubular necrosis, only supportive measures are done for tubular necrosis. But if patient has crescentic IgA nephropathy with little or no chronic damage, immunosuppressant medications are given, as induction for around 8 weeks, and then continued as maintenance therapy. If patient has nephrotic syndrome with minimal change on light microscopy, then treatment is done with steroids, for about 8 weeks or less. If more severe changes are seen on biopsy and it is considered that immunosuppressant medications will have no benefit, then no specific treatment is done. Hypertension is well controlled with ACE inhibitors and ARB medications as first-choice antihypertensive drugs, with a target BP of less than 130/80. Regular follow-up with a nephrologist is essential to monitor kidney function, proteinuria, and blood pressure. Kidney transplantation and IgA nephropathy. Recurrence of IgA deposition following kidney transplantation is common, affecting 50% of grafts within 5 years. But it has been observed that graft failure due to recurrence is rare. It is very important to know that early diagnosis and appropriate management are key to preserving kidney function and improving long-term outcomes for individuals with IgA nephropathy. Also, it must be noted that self-medications should always be avoided, as all these medications have their side effects and must only be used as prescribed by your nephrologist. If you have any questions or query, do leave us a comment.
Subscribe to my channel at YouTube at Gerdologist and press the bell icon for updated video. You can also follow my page at Facebook and follow me on Instagram. And if you like the video, don't forget to like and share the video.